Okay, so thank you, everybody. So today I wanted to expand a little bit on a talk I've given, about a year ago or so, and just to again, my objective today were really to open everybody's mind a little bit more to sort of alternate or other ways to think of the mitral valve and how we could approach our clipping or not clipping or surgery versus no surgery. The world is changing quite a bit in the mitral valve space, and I think we need to be thinking a little bit in that way. So the clinical problem we often have is we face patients with mitral insufficiency, and as a surgeon, just see if I can see a laser pointer, we tend to think of this kind of classification for us because this is the way we imagine we would repair valves. And we sort of separate the valves into scallops, so the anterior leaflet and the posterior leaflet. This is why when we look at a T echo, we like to see the view in that particular surgeon's view, because it helps us imagine the problems. And typically we would imagine problems as a type 1 problem where the leaflets are moving okay, but there's a failure to meet in the middle and there's a central jet. The type 2 is the more common that we would try to repair this. There's an abnormal or increased leaflet motion, and this would be a flail segment or a ruptured chordae, and these we can reattach. We can do lots of things to repair these. And then the more difficult ones are the type 3. They're restricted leaflet motion either because of a ventricular problem, dilatation, for example, or an infarction that would actually be pulling on one leaflet versus the other. And what's key to that is that the leaflets don't move above the plane of the annulus. So this is how we think of it. But the reality is when we think of mitral insufficiency from a clinical point of view in terms of indication for intervention, we tend to talk of it more in the primary versus secondary. And the primary would be to leaflet problem or chordal rupture. So this is a primary organic mitral insufficiency. These tend to do better with intervention than the secondary mitral insufficiency. And on the secondary mitral insufficiency, generally speaking, what I imagine them as the leaflets are okay, that's not the problem, but it can be due to a ventricular problem, but can also be due to an atrial problem. Is something that's a little bit more described now, is as your left atrium dilates, it can actually change the geometry enough to lead to mitral insufficiency. And that's being more and more described as a secondary form of mitral insufficiency. And as you can imagine, a little bit harder from a surgeon to think about ways to repair that, and replacement would be the only way, but also indication for those in secondary MR are not as clear in terms of benefit for surgery or for intervention in that sense. But for percutaneous intervention, perhaps there's a little better options there. So another way to imagine those two things together is if you think of this table here where you group them into type 1, type 2, and type 3 the way surgeons do, but you then have primary and secondary. This is the type of diseases you're looking at. And as I mentioned before, so they overlap all of them, but we think of them a little bit differently. And I want you to focus on the secondary here, the atrial MR or the ventricular. So either you pull on the leaflets from under or you change the geometry from above, it can still lead to an incompetence of the valve that leads to mitral insufficiency. While the ischemic is the more common we think about, is that there is an asymmetry in terms of the ventricle that pulls on one leaflet versus the other that leads to an indirect or sort of a difficult to assess often jet of mitral insufficiency that generally would be posterior directed, and it would make people think that it's an anterior leaflet prolapse when it really isn't a prolapse. It's just a restriction of the posterior leaflet, which would be the most common in terms of ischemic mitral insufficiency. So transcatheter based therapy today, I'll focus mostly on the mitral clip because it's the most widely used and the most described at the present, but there are coming, hopefully in the future, other means of doing this, but you'll see the trajectory of the transcatheter valve has been over a 20-year period. We forget that this started almost 20 years ago. And the principles are basically making an orifice like this into a 2-orifice valve. So a single orifice, they basically take the leaflets part in the middle or where the jet of mitral insufficiency is most prominent, bring them together and have a valve that's a bit smaller, but still not stenotic, and achieve that and improve efficiency. And this was described by Alfieri which is an Italian surgeon that does repair his mitral valves in this manner. Obviously, he's made his career doing that and can achieve good results with that. So what I mean by the trajectory of mitral clip, so the development in 2003 was the original beginning of the Everest-1 trial. So it shows you we're almost 20 years into this, to the point where it became, widely available in the late 2010s, and now is an accepted therapy that I'll show you in terms of indications and all of that. So that you see all of the trials that have come here from below and from above. These are advancements in the types of clips that are used. So it's been a 20-year journey, and that's resulted obviously in many implants. So there's over 1,000 centers in the world that perform these procedures in over 75 countries, 3 randomized trials. So obviously lots and 30,000 patients have had these types of therapies. So I thought I would show you just that, we talk about clip and sometimes people don't quite understand the mechanics of it. And I think it's worth just a 2-second video just to show you what it actually looks like. And so basically the clip comes through the septum from the right atrium, and then all of the time we spend is orienting that clip exactly in the plane that we want. And we use echo, and this is a tremendous effort from my anesthesiology colleagues in really getting the views that we need to really place the clip without getting caught in the chordae underneath, and in perfect angle to really go and grasp at the spot where the maximal amount of mitral insufficiency would be, and then clip, and then assess it by echo to see how that looks. And this is what you achieve. And if you're not happy, you release it and start again. And this is essentially how we do it. And a large amount of the time, we end up using 2 clips, not just one. So you can start at the worst part, and there are some technical challenges on the second clip, making sure where you put to make sure your second clip is going to be a little bit easier than the first. And then you release the clip, and essentially this is what you have. And hopefully you've made that better. So from a technical point of view, until you get it clipped, it can take from minutes to hours in terms of getting that organized. It seems like a simple procedure there, but it's taken us hours over time. So hopefully, if I can make my next, there we go. So what started all of this was essentially the Everest trial. The Everest trial, if for those of you would remember, was a trial that compared surgery in structural valve disease, so in primary mitral insufficiency mainly, to mitral clip. In that trial, not surprisingly, overall, surgery patients did better in terms of freedom from recurrence of MR or clinical outcomes compared to percutaneous. But there were 2 signals that were important in that trial that came out. Was regardless of that, in the older patients, there was a little bit more equipoise, a large error bars, as you see. And in degenerative disease, surgery was definitely better than the mitral clip, but functional disease perhaps was better with clip versus surgery. So this is what sort of the initial sort of findings of that Everest 2 trial, and the 4-year results were published, I think 2013. So essentially the trajectory of these trials were the Everest 1 that proved feasibility, Everest 2, and the 4-year result in 2013 published. FDA got approved in 2014, and then what came out as a major, there were 2 major trials, the COAPT and the Mitra FR. The biggest difference between the 2 was how rigorous the medical therapy and how big the ventricle and the severity of MR for entry criteria were, essentially showing a pretty significant improvement in survival and event-free survival in the device group versus a control group. And this is for the COAPT study, which really led for people, and certainly in the secondary MR world, in patients on optimal medical therapy, in which you still have functional class 2 symptoms or more, to be considered for mitral clip, assuming they're suitable candidates. And this is what opened up a lot of that world and was really the start for us of our NBHC program in 2019. So the growth in percutaneous device, and the reason for me for showing this slide is the growth has been tremendous even before the COAPT trial, which is in 2019. I don't have 2020 21-22 data, 2021-22 data. For some reason, they're not published at the present time. It's too bad, because my sense is that increase would be very similar in terms of growth in the United States. This is the US. But what's important to realize is that that growth is not limited to secondary mitral insufficiency. This slide is to illustrate that the majority of patients who undergo MitraClip are often primary mitral insufficiency patients. And this is in the pale blue. In the red is the secondary, and in the black is the mixed disease, and then undefined in the purple. So it shows you that 2/3 about of patients tend to be primary mitral insufficiency. And I'll show you what the recommendations are for that. It tends to be not the kinds of patients we assess for us here at the Heart Center, but having said that, it is something that we are using and have used, and I'll show you one case of that as I show you the slides. So I think what's particularly important for the MitraClip or the percutaneous mitral is the low procedural in-hospital mortality. So it's a very different in terms of invasiveness procedure than a surgical intervention would be. And this is where in the indications for primary mitral insufficiency in patients that we feel are higher surgical risk, this is something for people to consider. The mortality is in the 1% to 2% range. And the 30-day mortality, depending on how sick patients are, should be also good. And these are older results here, but they are low in general. So what are the current guidelines for primary and for secondary mitral insufficiency? So the current guidelines essentially in primary MR are patients in whom one thinks that the risk of mortality or surgical risk is high, or as long as one believes that the life expectancy in that patient is reasonable. So very similar to TAVI in terms of, so transcatheter edge to edge is a 2A recommendation for that group. In the secondary mitral insufficiency, this is really the types of patients that we see or tend to evaluate. But having said that, we tend to see them quite late in their process, that often we reach a point where their ventricles are very large, have severe tricuspid insufficiency, and often are not candidates because of that. And as you can see here, the COAP study clearly showed that in patients in whom the ventricles is very large, they're less likely to benefit. And again, with pulmonary hypertension can also be of less benefit, and obviously with tricuspid insufficiency on top. So these are the types of patients that would fit for that criteria. Recent guidelines, 220, just again to illustrate the big difference between previous guidelines from 2014 and 2020 is that there are now guidelines that are clear 2A recommendations for primary mitral insufficiency. That's a leaflet problem. It is reasonable in severely symptomatic patients with high or prohibitive surgical risk. So high from an STS point of view means an 8% mortality risk or more, and amenable. It is a reasonable thing to consider in these patients. And secondary mitral insufficiency, obviously the things we've talked about based on the COAP trial. So these are things that I need also my surgical colleagues to realize as options that are here for us to consider. So I would illustrate that first case. Hopefully I can get the other echo also to work. So this is a youngish lady in her 50s, presented with a heart failure admission, not on medical therapy at all. And this illustrates the classic sort of ventricle you might imagine. So not a great ventricle. There's clearly lack of coaptation of those leaflets, and those leaflets never move to the plane of the annulus. So clearly they're tethered, they're pulled down, there's severe mitral insufficiency. So responded well to medical therapy. So the goal is really to get them on good medical therapy. And then once on good medical therapy for a period of several weeks to months, reassess them, and if still symptomatic and clippable, then there is shown benefit in this patient. And this patient should be reevaluated by us because it's happened within the last year. So first presentation, investigations obviously included cardiac catheterization, all the things you might imagine. She had normal coronary, the mechanism of which is a dilated cardiomyopathy of unclear etiology, goal-directed medical therapy. Obviously, my colleagues from cardiology can speak to that better, but would include the newer generation medication like Entresto, and then have a reevaluation of that patient. And I think there is benefit in those types of patients. So this is a classic COAPT patient, and I'll go through the criteria of COAPT a little bit later on and what things to look at on echo that would be helpful in terms of predicting clippability. So this is a much older gentleman, I think 83, 84 years of age, is deaf. His neighbor, when you call him at home, you have to call his neighbor, and his neighbor goes to talk to him. He has reasonable social support from his neighbor, walks with a walker, is not super sturdy, and had a decompensation from heart failure point of view, so quite symptomatic now. Clearly a primary mitral insufficiency. You can see the ruptured cord. It's right in the middle, so at A2 and P2, sorry. And so that patient, in theory, fit criteria for clippability, and we put him forward for clip. And whoops. Oh yes, sorry. This is good to show. So again, I wanted to show this clip here is for those of you who do the echo. Very, very, very helpful to see this type of view for us on three-dimensional view. And you can see the scallop here in the P2 in the middle that is prolapsing. And if you could put some color, you could see that the jet would be in that central portion. And viewing that all again from under, you can actually see the mitral insufficiency right in the middle. So this would be ideal from a clip point of view, right in the center, maybe even fixable with one single clip. So this is a result after clip. So a significant reduction in mitral insufficiency. And so a good result for that patient in that particular category. So that patient, goes home in a day or two with no surgical intervention other than the venous puncture is a great outcome for that gentleman, which obviously is not super sturdy from a surgical point of view. Not surgery would not be possible. It is entirely possible. But again, it's balancing the risks and the benefit and making sure we do the right thing for each patient. So here's our experience. We're under 30, so we're not a huge experience. We're sort of trying to grow, but in general, we're sort of 5 to 6 patients a year on average. It's an early program. The majority of the cases we've done have been secondary mitral insufficiency. So we're a little bit of the opposite of what the current literature would support. There's been obviously some unforeseen events, passing of my colleague who was really spearheading this program, and the pandemic, which we're gradually building from that. These are the things that we look for based on the current trial, what the Everest 2 or the COAPT. So very important measurements to do is that, there should be no mitral stenosis. So we really want a nice mobile leaflet. And I know the guys who do the echo, you look at it and say, well, it looks fine. Leaflets are good. There's no stenosis here. We actually do need the measurement to see a 4 centimeter square. And the reason for that is if we're around that close, that 4 centimeter square, it changes our strategy for us that it may be a single clip strategy. In a single clip strategy, we would use a wider clip because there's 4 different kinds of clip. They're either longer or shorter or wider. So they can be short and wide, short and narrow, long and wide, long and narrow. So we actually pick those things based on those measurements. It's really important. So the transvalvular gradient's got to be low. The width of the flail segment should not be, so if you have a posterior leaflet prolapse, it can't be P1, P2, P3. If it's all of the leaflets that are prolapsing, you're not going to make that better. The flail gap, as you saw in that first echo that I showed you, it should be less than 1 centimeter as a gap, because it becomes very hard to grasp, and the tension in that leaflet gap would be too high and potentially tear that leaflet. The coaptation depth is what I mean by that is from the plane of the annulus to where the leaflet meet, that depth, if you measure more than 1 centimeter, and this is very similar for us as surgeons, we use in terms of predicting repairability in those types of patients versus replacement. And often in restricted leaflets, that depth is around that. And often you'll end up replacing the valve because your risk of recurrence is very high with a repair only. Very similar for the COAPT for these patients. You also need leaflets that are about 10 millimeters in length of mobility, both in the anterior and the posterior. So if you have a lot of calcium and not a lot of motion on that leaflet, you need 10 millimeter because the smallest clip is 9 millimeter long. It needs to grab the leaflet, not calcium. And then finally, in the COAPT trial, it was very evident that in the secondary, there are a few things that sort of predicted patients doing better, obviously on good medical therapy. They needed to have one heart failure readmission or increase in natriuretic peptide. Those are the kind of patients who benefited. They had to be more than 2 or equal to class 2 association, EF between 20 and 50, and they had to have an LV end systolic diameter of less than 70 millimeter, were more likely to benefit from the intervention. So if you see a ventricle of 110 millimeter, which I saw this week, that patient is really too far down the line, is very unlikely to help them with that type of intervention. So again, expected outcomes are good. Expected all-cause mortality should be low. This is where the benefit of this intervention is. And finally, the MR reduction should be quite significant at 30 days. A little bit more hard to predict in these patients, depending on the ventricle and a lot of other things at 1 year and 2 years, but you can make a huge difference in clinical benefit in these patients. And this is why their clinical benefits are better. And you can see the MR reduction is quite significant in those patients, to at least 2 grades of MR reduction in general. So our initial team, again, I want to provide some recognition of Saurabh, who spearheaded and was pioneer in terms of starting this program for us, and we've tried to continue this for him. So in summary, I think the treatment of mitral insufficiency now includes an increasing number of options that are available to us, so surgery versus percutaneous. I think mitral clips, while they're limited to patients that are high surgical risk, one needs to nuance this, that remembering that STS definition of high risk is more than 8% mortality or predicted mortality, and often we consider age and frailty as other aspects that are important. On the other hand, we also need to imagine that in young patients, to consider a mitral clip, you may preclude a valve repair in those patients in the future, and there's lots of literature to show that. So in low-risk patients in which you say, oh, yeah, let's just do a clip, it may mean that when that fails, a mitral valve repair would not be possible, and that potentially would impact those patients. So that can play both ways. The evidence would be that secondary MR in stable patients on optimal medical therapy with heart failure are patients. Primary MR in patients judged to be prohibitive risk. And I didn't add some of this here, but there is increasing evidence that in very extremist patients with acute mitral insufficiency, that these might be patients to consider, ruptured papillary muscle even, those types of patients that people are now considering these options and have used this therapy and have used it successfully in those types of patients to really get them better to the point where they could later on tolerate a surgical intervention. So we need to be thinking outside the box a little bit here. So striving for excellence in mitral interventions, I think peer review, heart team approach on mitral intervention is the key. Mitral valve surgery, including mini-invasive surgery, we provide. We do have percutaneous mitral valve repair now with MitraClip. I think the future will include percutaneous mitral valve replacement. Hopefully will come soon. And we have recruited a surgeon with specialized training in mitral valve intervention with Ivan Zelensov, and hopefully with him and myself, we can keep building this program over time. And obviously with my interventional colleagues who are working with this, we currently have Brett McGrath and Bob Teskey who are in the team, and Mike Rocca, who's with us now, has expertise and hopefully will provide some benefits and some help to us on the MitraClip side of things. So with this, I will end talking. I've taken a long time here, so I'll stop my share. There we go, we're back on. Okay, any questions?
Thanks, JF. I put my question into just your view in the chat, but what is your, I noticed the separation of curves seemed to take about 6 months before you started to see those curves. And I think there was secondary MR, if I remember the slide.
In the co-op, yeah.
Yeah, so for the group, your view on the duration in secondary MR with severe, in secondary MR that is severe, your view on the duration of optimal medical therapy before you would consider doing an intervention?
Yeah, we currently use 3 months based on what we think is reasonable and probably based on that study on the COAP, but is it really necessary to do 3 months? I don't know the right answer to that, to be honest. And the reason I say that is that this coming out of evidence that it can be used in more acute settings where you know that you're not going to be able to stabilize them medically and achieve that at 3 months. So I think it warrants for us to sort of change a little bit our frame of mind in those patients, the one that tolerate medical therapy and do well. I think the time is going to be of benefit to you, but there are going to be a subset of those that are not going to be able to tolerate well and may actually continue to decline, and you may lose your window to help them.
So, in follow up to that, then the referral pattern for physicians outside our zone in terms of thinking about who they should refer, at what point?
Yeah, so we can use the triage system the same way to refer for mitral clip or mitral insufficiency. I think all of us here, we are quite acute and they come my way and they come to Brent's way and or to Bob's. They will make their way through the triage system to be asked and a question to that. So I think the regular pathway is as helpful. Obviously, if you want to give me a call, that's also very helpful. But there is a standard way to reach us.
And Jeff, in a similar vein, do they all have to be severe? You know, if you see one that's a 3+ MR, but really looks clippable and they're not doing well and they're not good for surgery, would that be a potential?
Yeah, the trial uses 3 and 4+. So and so there's a proportion of those patients were 3+. We have traditionally not done that here quite correctly, but I don't know the answer. Certainly the benefit is in the 3+ also in that particular group. So good question. It would be something for us to discuss as a group to, you know, this looks severe, this looks clippable, we could help this person. Absolutely.
Thank you.
All right. Thank you very much. Thank you, Mahmoud, for the comment. It is astounding that we can put a clip. It is sometimes crazy and frustrating. And I'm sure if you ask Ashley O'Brien or Jennifer Cloutier, who do the echo for us, they are tired. They go from one plane to the other, biplane 3D, biplane 3D, and it's nonstop for 3-4 hours sometimes. So your eye is going cross-eyed trying to make that work, but it does work. I mean, their help is invaluable. All right, thank you, everybody. Have a good day.
Thank you.